So good afternoon, and thank you to Massimo and to Martina in particular for the invitation. Can everyone hear me okay? There's some question about whether the mics are working all right. So I'm a bit soft-spoken, so I'll just try and talk up a bit. So Martina said many of you haven't been to a PSC support forum, and I'm one of them. I haven't been to one before either. It's a very exciting time for the clinicians as well. We had a patient support forum a few weeks ago here, and a different condition. It was a really interesting and informative interaction about some of our clinical work, and it's informed our research ideas over the next several months, and I hope the same will come today. So I'm trying to give an overview of PSC, and we're going to talk also about transplantation. Doug's going to cover that, and then cover some of the research ideas we're covering. So it's a picture of UCL on a sunny day, and Royal Free just 5 kilometres away, so here we are. And much of our work is based here, and I've been given the task of giving an outline on these 3 areas. So natural history of PSC, common symptoms, and then a difficult one which I didn't quite know how to tackle. I'm really getting mic'd up. And also how to be a professional patient. So I'm not sure I'm going to be able to answer that, but I'll try and give you some insight on that. So we're talking about a condition of the liver, a normal MRI scan. And in terms of natural history, this is the definition we typically use for primary sclerosing cholangitis in our publications and background. So a chronic syndrome characterized by inflammation and fibrosis of the bile ducts. And the condition is present if you've excluded other possible reasons, such as injury related to surgery, etc. And it's often involving both the ducts inside the liver and outside the liver, the extrahepatic ducts. And onset more often in young men of average age of approximately 40, etc., although there's some evidence that's changing a little bit. And the natural history, unlike some other conditions we deal with, like primary biliary cirrhosis, is often variable, a bit unpredictable. We can't always be certain what's going to happen. Sometimes people become more jaundiced with time, progressive cholestasis. I have a particular interest in endoscopy. I'm an endoscopist and look after people who have dominant strictures in the bile duct and with gallstones. And then obviously some people can develop portal hypertension and complications of that, including liver failure requiring close liver support and even transplantation. And one of the complications that we are aware of and look for very commonly is bile duct cancer, and that happens in up to perhaps 1% of people with particular types of strictures each year. And there's also some evidence, of course, that people with PSC have extra risks for other cancers, particularly bowel cancer if they have inflammatory bowel disease, and there's also some evidence from the Scandinavian countries of pancreatic cancer and gallbladder. So the common association, of course, with PSC is colitis, in particular ulcerative colitis, although sometimes Crohn's disease. But paradoxically, it's not always those people with severe colitis who get PSC, and sometimes we see it's the other way around. The people have mild colitis or having had colitis years and years ago who develop PSC, and the outcome's unrelated to the activity of that condition, which is present in most patients with PSC. And the other thing we're concerned about, of course, is that people with PSC have an increased risk of developing complications of the colitis, in particular dysplasia, so precancerous changes in the bowel, or even cancer, and that's higher than those people who just have colitis alone. So these are all things that we look out for in people when we see you in clinics and in the wards. We also need to consider the natural history. That's very hard to be able to tell the individual person what we think might be the near future. Some of the data out there's a very large Swedish study, there's very large Dutch studies, and the UK is also putting together its resource, and there's an international PSC study group which are now looking at all of the European data, and on average, people can give average survival times in terms of needing from diagnosis to, for example, transplantation, and those figures range from 12 to 18 to 21 years, but they're very variable and difficult to translate to the individual sometimes. Some of the variants we look after, of course, people with small duct PSC, it's a smaller number of people we see. It looks very much the same on liver biopsy, but on MRI or ERCP, you don't see those classical changes that you do in straightforward PSC. So people have a normal cholangiogram, a normal investigation of the bile ducts, and they seem to have a lower risk of some of the complications. Progressing to strictures and also progressing to bile duct cancer is very rare indeed. It's less common. There's only a small series so far, and I've just put down there at the bottom the first largest joint study from Oxford and Oslo about patients with small duct PSC. So none of those patients developed the complication of bile duct cancer, and only a few percent, 12%, developed late-stage liver disease. The other condition we keep in mind about, of course, is this condition, which we used to call autoimmune pancreatitis or autoimmune sclerosing cholangitis. Now it's called IgG4 related disease or IgG4 systemic disease, because one of the classical diagnostic features is the presence of a particular immunoglobulin, IgG4, in biopsies and even in serum. And you see strictures like this, as we see, extrahepatic ducts and also the ducts inside the liver being involved. But the difference in PSC is that when we treat this with steroids, almost all the time everything goes away, and the jaundice that people had, sometimes 200 or 300, returns to normal within a few weeks. And so that's a condition that we're now looking at very closely in all people with a new diagnosis, and rethinking about it in people with an unusual course with their PSC. So in terms of natural history, it's not particularly rare, this condition people have. It affects at least 5% of people with ulcerative colitis, which is, after all, a common condition coming to gastroenterology. So most hospitals might expect 2 or 3 new patients per year. There's some trends in terms of we're diagnosing more people in terms of small duct disease or very mildly abnormal liver tests, those kind of things. And still the outlook's very variable. Doug's going to cover the issue of liver disease and the indications for liver transplantation. But predicting those people who might develop precancerous changes in their bile ducts still remains a big challenge for us. So that's my conclusions from natural history. As I've said, median survival is very variable. Most people initially starting without symptoms at diagnosis do develop symptoms over time. And again, some of the big studies, for example, this one going back to almost 20 years ago, that over a course of 6 or 10 years, that maybe 1 in 5 people with a diagnosis of PSC may even require a liver transplant. So what symptoms do people complain of when they come to see us or when they first have a diagnosis? So this is a slide from one of my previous directors of hepatology, Professor Roger Williams, and I think things are still true that we see people who don't have any symptoms at all, picked up as, of course, they've been in the inflammatory bowel disease clinic and have developed abnormal liver tests. That accounts for a minority of those people. They tend to have no symptoms, tend to have a slower change over time, and then the more classical, more common scenarios, those people who come to attention, come into a liver unit with fever or with pain or jaundice, pruritus, so itchiness is a common symptom, as is fatigue. This is the summary of symptoms that were presented in the PSC support survey, as you can see, and the common ones, and thanks very much for sending this around, the common ones, as you can see, itching, right upper quadrant pain, fatigue, depression, and several others, jaundice, portal hypertension, these sort of liver-related symptoms being less common in this group that was surveyed over the previous 4 weeks earlier this year. So one of the common symptoms that I see is in people who've developed strictures. So a dominant stricture is defined as that which has resulted in narrowing of the bile duct so that the person develops abnormal liver tests and the bile ducts above the narrowing have become larger, so bile's not flowing normally. And that happens in perhaps 10 to 20% of people. Some series say even higher than that. Always the concern in that situation is that could that be a warning sign of developing precancerous or even cancerous changes, which, as I said before, can occur in between 1 in 200 to even 2% of people with these so-called dominant strictures. And one of our big tasks in endoscopy and in liver unit clinics is to try and define and make sure that's not the case, and to give appropriate treatment endoscopically, and to define who needs to have a transplant at the appropriate time. These are old data from our previous series, so we've had an endoscopic interest which was based at UCH, now based really here. And this is a series of over 13,000, and when we finally published this, about 17,000 ERCPs. So people with PSC don't come to needing an ERCP very often. So we did a total of 100. We saw a total of 130 patients over that 20-year period who were requiring stenting or using balloons to dilate strictures or taking samples, etc. And as you can see, the bile duct cancer, people needed a lot of intervention sometimes. So people on averaging six endoscopies, and we saw the development of bile duct cancer in some patients, but only in those patients who had dominant strictures, not in those patients who've got just abnormal intrahepatic bile ducts. So there's not very many randomized studies out there to tell us exactly what we should be doing, but based on the studies from large centers like ourselves, we are very cautious about recommending doing endoscopy in such patients. We use non-invasive scans, CT and particularly MRI, to try and define who we should be managing. And the current consensus, and Doug is going to just touch on one of the current international trials that we are about to join, is either using balloons to stretch open neck strictures or even putting plastic stents in temporarily, and that results in clinical improvement. But we need to also be aware that there comes a time when endoscopists should step back and people should be managed in the liver unit. So what do we do to try and make diagnosis? Just a couple of slides on that. So classically we use brushes up in the bile duct. This is a biliary brush on the left-hand side, or we take small biopsies. And again, I think in the research side, Doug will talk about one of our big interests is in trying to develop new markers for precancerous changes so that we can improve on some of our early data. So at present, we don't think there's any evidence to support, for example, recommending a person having an annual ERCP and endoscopy. But there are things coming around, and this will be mentioned soon. So we have some new technologies which are coming up so that we can look inside the bile ducts directly. So much the way, same as a colonoscopy, looking at the bowel directly. So we now have the technology to look inside the bile duct directly and look at the lining. And then we also have this particular technique which we've started just a few months ago and are developing it for the bile duct, so we can actually look at the cells inside the bile duct directly. So this is 1,000 times magnification. So we can actually look at individual cells within the bile duct with appropriate techniques. So it's still invasive, but we think it may have a role in being able to certainly troubleshoot when we couldn't be certain what was going on, maybe being able to add to an answer for people. So but what would be much better would be to have a non-invasive scan, a non-invasive test for early warning signs for bile duct cancer. At present, there isn't anything out there really. Some of the tumour markers we have in the blood don't work, and all of the type of non-invasive scans that we do are not sufficiently good enough to pick up very small things. So at present, there are no established non-invasive tests. And this is another slide from a famous PSC clinician, and probably many of you have seen this slide. So this is one of Dr. Chapman's slides, the holy grail of screening tests. And what we want is we want a test which is non-invasive, it's simple and safe. It gives an answer which is correct, high sensitivity, high specificity. It'd be great if it was low cost, and we do have an effective treatment available, of course. So, that kind of test is really a blood test or a urine test, something like that. There's a lot of work going on, which we'll cover later in the research side, about developing those kind of investigations. We invite you all certainly to be part of that in terms of providing blood and other samples for some of the studies that we're doing. So turning lastly to my most difficult area, I suppose, how to be a professional patient. So I can't tell you how to be a professional patient, but I just put a few slides together about the UK liver plan, which is kind of relevant and gives you an idea about what the government says we should be doing. This is an older slide from the British Society of Gastroenterology from 2006. This was the National Liver Plan proposed by clinicians at that time. So, initial screening in primary care. So now it's required for new patients going to general practitioners to be screened for things, including liver function tests and having their body mass checked and having their alcohol intake recorded, all those things. So initial screening in primary care, we wanted to have defined pathways, so from primary care into secondary care for patients with abnormal liver tests. We wanted to look after patients in a multidisciplinary way, and that's very much established now, I think, certainly as part of the National Cancer Plan, and also in liver units, that it's not just a liver specialist or a gastroenterologist that you see in a hospital like this. You see a whole team of people. Networking, so national interactions, and and the plan was that individual hospitals and centres should know what their outcome and effectiveness, etc. This is again, the National Health Plan, which I just mentioned. This alcohol intake, assess viral risk for viral hepatitis, assess body weight, and this is interesting. I think people here will certainly have a view on this. The current recommendations are that people with liver disease, which is stable, should be looked after by the general practitioner or in the local hospital and come to liver centres when they have particular complications or so-called decompensation, and that's the current guidelines. This is the most recent national presentation. So this was published in 2011, the NHS Atlas of Variation for people with liver disease. And so we have those guidelines, and like all guidelines, they're not adhered to effectively all around the country. One of the big issues nationally, of course, is this inexorable rise in the frequency of liver disease overall, particularly in the northern part of the country. And we've overtaken Italy and France in terms of frequency of liver disease, so declining frequency in those countries and many other European countries, but a rising frequency of liver disease overall in the UK. Much of that, of course, is because of alcohol and also body mass index, and that's obviously driving much of the national liver agenda. But some of the experiences of liver patients, and this is a document presented by the British Liver Trust and also the British Association for Study of the Liver, the UK one, has also been asking patients their experiences around the country. And some of them are like this, and this is presented at Basel. So a person with abnormal liver tests goes to their general practitioner, and it's often the situation that people come up with some barriers about not considering a diagnosis which is not related to some of the common things, so alcohol and large weight. And so people with autoimmune diseases or people with PSC sometimes not being thought of. And so this is one of the quotes there from the patient. The doctor basically told me that only drug users and big drinkers get liver disease. I tried to tell him that I already had 2 autoimmune diseases, and I thought that was the cause. So this is data from your PSC support network. That's coming to an end now. So about half of you are being seen in a PSC clinic. I don't think that's all PSC clinics. I think that was just the 14 that had declared dedicated PSC clinics. So I presume that many of the other 50% are in liver clinics with people who have an interest and understanding of PSC, but obviously there must be variation around nationally. So what's going to make a fantastic national liver program? These are some of the things that have been put forward by the National Liver Disease Strategy. So we all want to identify liver disease early. We want to improve access for people to have testing. That's at primary care, and also rapid access into secondary care for surveillance and monitoring. And we all want and are looking for patient involvement in all of that process. And that's along the top there. And all those kind of things are what's being proposed by the national government. They also in that document put forward some examples of good practice around the country, so it's not all doom and gloom. There are some excellent centres around, and they put some examples of that. So Nottingham with alcohol liaison, Southampton a traffic light triage, so if you're well, you stay out of the teaching hospital. If you're having any problems at all, a very rapid access into multidisciplinary care and things like that. And Birmingham were highlighted for electronic records and healthcare teams. So what are we doing in London? Because it's our first visit and hosting of this meeting in London. There are some things which are relevant, I think, to PSC. And one of them is that we've really developed London as a network. So rather than this hospital and that hospital, all of these hospitals in the North London network have all signed up to common management. So we all have similar programs and protocols, and we look after patients in the same way. And the main hospitals, as you can see, is the Royal Free and Royal London, where the surgery and transplantation, certainly at the Royal Free, takes place. So some of the things that are innovative, I think, here in our network is we've been looking at telephone clinics, and that's been very successful as one new thing. So still keeping in contact with patients, and we've got audited data that's liked by patients. It means less travel. Some people come from Cornwall and from Wales, and many of you have probably travelled a great distance to get here. So we can keep in contact, but still be able to avoid having to come in for those routine clinic appointments. And one of the endoscopy things we've been able to do is to have more endoscopy access. So we're aiming towards really having immediate access to therapeutic endoscopy, and to have that as comfortable as possible with anaesthetist-delivered lists. the whole cancer network, everyone needs access to a cancer nurse if they have cancer. And so everyone with liver disease should have access to a liver disease nurse. And that's not present all around the country, but that's certainly one of the goals. And one of our big areas as well is all these new technologies coming through, which we hope is going to improve the care of patients with PSC. So we'll go through some of those later. But some of these new technologies and biobanking and development of non-invasive biomarkers is the key. I think this is my second last slide. This is one new thing which has just been funded. Now it's slightly cancer oriented. It's been funded by Cancer Research UK, but it just gives you an idea of how things are moving within London Cancer. So the idea is that we have funding now for multidisciplinary diagnostic centres, and so the idea is that so if a general practitioner sees a patient that they're concerned about, they do an immediate electronic referral, and we will see that patient immediately within 24 hours. Now, we have those mechanisms in place already for some conditions like jaundice. The idea is that the patient then comes into the centre, has all their information obtained through a clinical coordinator. They have their imaging done on the same day. They see a hepatologist on the same day, and a decision made about what needs to be done or what's the next step really very quickly. And that's what we're being funded for, and I think it'll be relevant to some of those conditions that we keep an eye on. So people with liver cancer or people with primary sclerosing cholangitis. And the idea also is that we'll have integrated care across the whole network, and that will then lead into the UK system. So I think many of those things, there's a lot of things coming in information technology. People are looking at lots of apps. Everyone's very keen on applications now. So if you have any problems, get instant access to your hepatologist or get instant access to your blood tests, all those kind of things. That's all coming. And in terms of surveillance, we'll have a central network team which will be much more accessible, although they're accessible now, we hope, than has been in the past. And that will also improve our ability to detect cancer and also invite people to going into our clinical trials that are ongoing. So I've just highlighted some of the emerging themes. I think from our point of view, what makes a professional patient? From our point of view, I think we approach seeing people in clinic with an optimistic way. There are things which are improving in this condition. We tend to take a problem-oriented approach. So your jaundice, we'll manage that. Where you have a stricture, we'll manage that. We're a bit cautious about being, about what we're saying, and we want to be as readily available as possible, and give as much information about the condition so that you can make effective decisions, as can the GP. A lot of IT is coming, and I think the London Cancer Model is the way that we'll be going forward with this condition, and that'll be in a collaborative approach through UK PSC and also the international PSC study group. So Doug's going, and research is the big area, and Doug, I think, will cover this, but this is just some of the outcome, this is some of the responses on your PSC support survey that, all of you would welcome non-invasive tests as part of a research program, and we invite you into those things, and some blood tests, and obviously, understandably, there's reservations about invasive testing for particular conditions. But nevertheless, I think the conclusion in the document that there's a strong willingness among patients with PSC to support and facilitate research, and that's fantastic. So this is my last slide. This is a slide which I've cobbled from one of our pediatric hepatologists who presented at the PSC support meeting in the States a couple of years ago. But I think it's a reasonable summary. So, from the patient's point of view, you have a team. You need to assemble your team, I suppose. Your gastroenterologist for your inflammatory bowel disease, your hepatologist for your liver disease, and your primary care physician. We need to provide time, and you need to insist on time to talk about your results and adequate time to discuss those things. And it's not just about looking at today's results, but also having a perspective over the future and getting some understanding about what to expect over time with PSC. Care of associated medical conditions, particularly inflammatory bowel disease, surveillance, ultrasound, for example, of the gallbladder, which we do sort of on once a year, and very much support and welcome people participating in research studies and being an advocate for this condition. So I'll stop there with a picture of the Royal Free Hospital, and I'll thank you very much.